Welcome to this CyberSite webinar. Today we'll be talking about congenital nasolacrimal disorders and management. I'm Suzanne Freitag. I'm the Director of Ophthalmic Plastic Surgery at Massachusetts Eye and Ear Infirmary and Harvard Medical School in Boston.
And hi, I'm Nandini Bothra, and I practice at LV Prasad Eye Institute at Hyderabad, India.
Congenital nasolacrimal duct obstruction is quite common. Reports range from 1.2 to 30% of full-term newborns have this condition, but a number of about 6% is often quoted. It's higher in children with craniofacial disorders and other anomalies. And if persistent, it can lead to chronic problems into childhood and adulthood with epiphora and the risk of infections such as dacryocystitis, orbital cellulitis, or bacterial conjunctivitis. A brief look at the anatomy of the lacrimal system is demonstrated on this slide. So there's an upper and a lower punctum in the medial part of each eyelid. These form an upper and lower canaliculus, which extends in about 90% of individuals to form a common canaliculus as it enters the lacrimal sac, and about 10% of people lack this common junction before entering the sac. The sac then moves downward, goes through the maxillary bone in the section called the lacrimal duct, and then this empties into the inferior meatus of the nose under the inferior turbinate, where there is a structure called the valve of Hasner. The development of the lacrimal outflow system begins with a thickened ridge of surface ectoderm cells at the naso-optic fissure. At 12 weeks, these cells divide into the surrounding mesoderm, forming a solid cord of cells. We'll see this on the next slide. This elongates in a direction from the future medial canthus to the nasal cavity, and then this canalizes to form a hollow tube. And this should be complete by about 6 months of gestation. And then the canaliculi open into the lid margin around the 7th month, just before the lids separate. And here's a diagram. On B, you see an eye and a nose, and you see this little cord of future lacrimal tissue. And then you can see it extending toward the nose and toward the lids. And then eventually everything joins up and canalizes.
So as Dr. Freitag was saying right now, so what happens when the canalization occurs? So if you look at the development of the nasolacrimal system, the canalization actually begins in the lacrimal sac, as you can see in the second picture. So you see these are various vacuoles, the white spaces that you see in the lacrimal drainage passage. That is where the canalization begins in the sac, and then it proceeds both proximally and distally almost together. But because the proximal passage is slightly smaller, it sort of completes canalization by 6th or 7th month of intrauterine life. But in the distal portion, because it's slightly longer, it completes at birth or just after birth. And that is why in congenital nasolacrimal duct obstructions, the most common membrane that you see, which is imperforate, is the distal end, that is the nasolacrimal duct. Next. So when we say congenital nasolacrimal duct, as we already saw in the embryology, the lower part of the nasolacrimal duct has a membrane. Now, for that membrane to break, it either automatically breaks at birth or breaks after a few days after the birth. So how does that happen? So when the child is actually sucking in and taking and increasing the intranasal pressure, at that time, this membrane automatically bursts open, which usually happens at about birth or just a few days after that. So if it does not break, that is when we get congenital nasolacrimal duct obstructions. Next. So when you see a child with NLDO, so what do you ask the parents? The first thing is, when did you first observe watering? So now, as we know that it can either be immediately at birth or a few days after. So usually if you ask the parents, they would say that the watering started maybe a month or so after the birth of the kid. Now it can be unilateral or bilateral. And the most common presentation is watering from the eye. And the second most common would be mucoid discharge, which is forming on the surface of the eyelid. A very characteristic phenomena is that this discharge generally forms when the child is sleeping, and therefore when the child wakes up, it forms like a thick crust on the eyelids, and it makes it impossible for the child to open the eyes until you actually clean the discharge away. And sometimes when this discharge starts collecting into the sac, you press the sac and then you get this typical mucopurulent discharge which comes out from the nose. Next. So now look at this picture. So look at the right eye. It looks absolutely normal. But when you look at the left eye, you see that the tear meniscus height is visibly raised. You will see that the lashes are actually sticking to each other, which is what we call as the matted lashes. And then you see excess of the epiphora, which is overflowing onto the skin of the eyelid. Right? Next. So the first step when you evaluate is to determine whether this tearing is because of overproduction or is it because of outflow obstruction. Can you press next 3 times, please? And 3, yeah. So if there is overproduction, when would that happen? When there is reflex watering from the eye. When does reflex watering happen? Whether there is an infection in the eye, or if you look at the first picture in the below panel on the left, you will see that there is on the left-hand side, there is an entropion, or what we call as an epiblepharon. So when you have an epiblepharon, the lashes are turned inwards and they touch the surface of the eye, and that is when you can have watering. The second picture shows an acute glaucoma child. So in a case where the intraocular pressure is so elevated, even that can cause watering. And if you look at the third picture in the right eye, you see that the cornea has a keratitis, and therefore that can cause reflex watering. So first we need to determine whether it is because of overproduction or whether it is because of outflow obstruction. Next. So here history will play a very, very important role. As we discussed earlier, the first thing you should ask is when did it start? It should be a few months or days after birth. Then it should be constant if it is because of obstruction. If it is not because of obstruction, it will not be constant. So if there is an obstruction, there has to be a constant outflow of tears. Second, the third important thing that you should ask is it associated only when the child has upper respiratory tract infection? Because upper respiratory tract infection can cause reflex secretion and overproduction and can cause epiphora. So if it is associated only during the episodes of URTI, we should wait until the infection subsides and re-evaluate the child. Then whether there is any history of discharge or epiphora, we will come to why this point is important later in the presentation. And the last part is whether the eyelids stick after waking up from sleep in the morning. That is because of excess accumulation of discharge. Next. So when we evaluate, the most important step is in a kid, we cannot do a syringing. So how do you know whether it is because of an obstruction? So you do something called as the fluorescein dye disappearance test or a dye disappearance test, right? So go to the next slide, please. So you mix fluorescein, you just put about 1 drop of fluorescein stained saline in the inferior fornix and just leave it there. You always put it in both the eyes. You wait for about 5 minutes. After 5 minutes, use the blue or the cobalt filter on your indirect ophthalmoscope and just look at the kid. So if you look at this picture, which is a beautiful picture, thanks to Dr. Freitag, you look at the right eye. You see a nice elevated tear meniscus height. Whereas you see in the left eye, there is absolutely no fluorescein. But what do you see in the nose? That all the fluorescein from the left eye has actually drained into the nose, and you can actually see the fluorescein shining in the left nose. Whereas in the right nostril, you cannot see anything. That is because the fluorescein has not drained inside because of an obstruction. So this is a very important test in children. Okay, next. So Again, just reiterating all the signs that we spoke about: matted lashes, elevated tear meniscus height. You can see mucoid discharge there. And if the sac is dilated, you press in the area of the sac, you will see regurgitation of discharge. Next. So what are the causes? The main cause is the membrane at the lower distal most end at the valve of Hasner did not break at birth. So when it does not break, it leads to congenital nasolacrimal duct obstructions. Next. So when you have a congenital nasolacrimal duct obstruction, they are again divided into whether it is a simple obstruction or a complex obstruction. I want you to look at the first picture on the top panel. So that one is called as a simple obstruction because there is just a small membranous obstruction at the end of the nasolacrimal duct. So what you see in the picture is the curved structure is your inferior turbinate. The larger curve, which is like this, is your lateral wall of the nose. And in between, the space is your inferior meatus, which is where your nasolacrimal duct opens. So if you see, look at the first picture, there is just a small membranous obstruction. But look at B, C, D, E, and F. All of these are complex varieties. Now in B, what do you see? Look at the nasolacrimal duct. It reaches all the way up to the floor of the nose. So here, if you don't have an endoscope, there is going to be a problem because you will hit the floor. You will think that you've opened it, but actually it is not opened. So you have to actually medialize your probe, get into the inferior meatus and break that membranous part of the nasolacrimal duct. Whereas all the others, that is C, D, E, and F, the membranous part of the nasolacrimal duct is not formed at all. Here in the C, it is opening into the inferior turbinate. In D, it is opening again into the inferior turbinate. In E, you can see it is opening into the lateral wall of the nose. And in F, the lower part of the nasolacrimal duct is not formed at all. So all of these varieties, starting from B to F, are complex variations, whereas a membranous obstruction is a simple variation. Next. So a simple obstruction, as I told you, if you see the bottom picture, you see on the left-hand side, the bulge that you're seeing is actually your dilated nasolacrimal duct. And then when you come in with the probe, if you look at the picture on the right, you will actually perforate through this membrane. You use your periosteal elevator to lift that probe so that you break the nasolacrimal duct in that area and enlarge the opening. So this is an example of a simple congenital nasolacrimal duct obstruction. Next. Whereas if you look here, so where do you see the probe coming out from? You see that the probe is coming out from the inferior turbinate. So this is actually a misdirected nasolacrimal duct into the inferior turbinate. If you see a picture like this, you have no other option but to go ahead with a DCR surgery because it is not going to solve, your problem is not going to solve with just a simple probing because it's a misdirected NLD. It is not in the correct position and your water is not going to flow or the tears are not going to flow through a bony membrane like this. Okay, next. So what is the treatment? Up to 1 year of age, you will do lacrimal sac compressions. Now, why up to 1 year of age? Why not up to 5 years of age? So McEwen and Young in 1991 observed a few kids across the spectrum, that is from the birth up to 1 year of age. And what they saw was up to 95% of these kids actually present within the first month of life. That is why history is very important when the epiphora start. And the second observation was about 96% of these resolved spontaneously. Now, if you look at the table there, you will see about 95% resolution occurs in first 1 month. And at 12 months, the rate of spontaneous resolution goes as low as 0%. So that is based on his observation that we suggest that do lacrimal sac compressions for up to 1 year of age. Try to see if there is spontaneous correction. And if there is spontaneous resolution, well and good. If not, then after 1 year of age, take the child up for probing. Next. So let us understand how to go ahead and do the compressions.
Hello everyone. Today, let us understand the correct technique of lacrimal sac compressions done on a child less than a year old and suffering from continuous watering from the eyes. The first step is to hold the child firmly. Hold the head and make sure the head does not move while doing the compressions. Now use your index finger to do the compression. Make sure that your nails are trimmed. Feel for the edge of the bone next to the nose and below the eye. Using firm pressure, gently press towards the nose, directing the force slightly inwards. Continue these compressions 10 times per sitting. At least 4 such sittings per day have to be performed. A crying child should not be a cause for concern and should not be a reason to discontinue compressions. Now let us understand this process again. It is always good to try these compressions first on yourself to understand the amount of force needed during the compressions. Using your index finger, feel for the edge of the bone as described earlier. Start the compressions by gently pressing towards the nose, directing the force slightly inwards. Continue this for 10 times per sitting. 96% of watering in kids resolve spontaneously or by lacrimal sac compressions by the age of 1 year. So the correct technique can go a long way to avoid any further procedures on your child.
Okay, next. Right. So Dr. Freitag, you want to continue?
Okay, so if you find yourself in a situation without resolution of the problem, by the time the child is about 12 months of age, you want to think about formal intervention. And so lacrimal probing and irrigation is the most common first intervention. And so indications would be on the top picture, shows a congenital dacryocele, also called dacryocystocele, or called amniotocele. And this is a situation where fluid is accumulating in the lacrimal sac, but you're not able to get it out with compression because the valve of Hasner at the bottom is a problem, but at the top near the common canaliculus is the valve of Rosenmuller, and this can also be obstructed so that you can't push the fluid up or down and it's stuck. The middle picture shows a child who's developed dacryocystitis with a little bit of cellulitis infection in this lacrimal sac, and he appears a little bit older, so he has had a while for bacteria to grow. And then the lower picture shows a more significant lacrimal abscess. So these patients all deserve intervention. Next.
Yeah.
Nandini, do you want to narrate your video?
Endoscopy guidance has enhanced our understanding of the anatomy, physiology, and pathology of lacrimal disorders. The development of endoscopic techniques has contributed to the development of minimally invasive lacrimal procedures, and congenital nasolacrimal duct obstruction is not an exception. So let us go through the procedure of irrigation and probing under endoscopic guidance. The instrumentation needed apart from endoscopy system is mainly a 1 ml syringe, 23 gauge cannula, short taper nettleship punctum dilator, Bowman's lacrimal probe, periosteal elevator, and suction cannula along with the apparatus. The procedure is performed under short general anesthesia with a laryngeal mask airway. Nasal mucosa is decongested with cotton buds soaked with 0.025% oxymetazoline. The upper eyelid on the unaffected side is raised at the junction of the medial and the middle third from the margin such that the area of the punctum and the horizontal canaliculus is visible and is taut. The upper punctum is dilated using the short taper nettleship punctum dilator. The dilator is inserted
perpendicular to the punctal opening and then is turned to a line parallel to the lid margin to enter the horizontal canaliculus. This procedure is then repeated on the affected side. Irrigation is performed using a 1 ml syringe and a 23 gauge straight cannula to confirm the nasolacrimal duct obstruction. Bowman's lacrimal probe using age-appropriate size is then used in a similar way. First, it is inserted perpendicular to the punctum, then turned horizontal such that it is parallel to the lid margin and advanced till hard stop is felt. The probe is then turned perpendicular and advanced in a downward, lateral and posterior direction. The probe is brought to a halt the moment any obstruction is felt. The cotton buds are removed from the nasal cavity. A 2.7 mm 0-degree endoscope is used to visualize the nasal cavity. The inferior turbinate is medialized using the blunt edge of the periosteal elevator, and a direct view of the inferior meatus is obtained. Probe is then advanced and the obstruction is overcome under direct visualization. The probe visualized in the meatus is then lifted with the help of the elevator to widen the opening. Irrigation is done to confirm the free passage of distilled water. A retrospective interventional study at our center analyzed the profile and outcomes of congenital nasolacrimal duct obstruction which had undergone probing elsewhere without endoscopy guidance and were referred to us for a second or a third procedure. 100 eyes of 82 children had experienced failed probing without endoscopic guidance done elsewhere, of which 63 cases underwent intervention, this time under endoscopic guidance. Of interest were 35 cases of simple congenital nasolacrimal duct obstruction, which had a simple membranous obstruction at the nasolacrimal duct opening. Post-intervention, 32 of these cases had a successful outcome with probing under endoscopy guidance, and the remaining 3 had developed atonic sac and were successfully managed by dacryocystostomy procedure. Of the 28 cases of complex congenital nasolacrimal duct obstruction, 12 cases had bony obstruction and severe atonic sac requiring dacryocystostomy surgery. The remaining cases were treated with probing with or without Monoka-Crawford stent or balloon dacroplasty under direct visualization using endoscopy with good outcomes. So to conclude, endoscopy guidance helps identify a variety of congenital nasolacrimal duct obstruction subtypes and facilitates the performance of additional procedures along with probing in a single sitting to achieve optimum outcomes. Thank you.
Thank you. Next, please. Yeah. So basically, before we just move ahead, the whole point of showing that previous video in so much detail was to understand that whenever, whenever we do probing, it is very, very important to learn it the right way and to do it under endoscopy guidance. Right. Over to you, Dr. Freitag.
So there have been a number of studies looking at success rates for initial probings, and there are definitely some trends that become obvious by the child's age, and we've alluded to some of that already, but presenting a little more data, Steger looked at a large number of patients, over 2,300 patients, And they found their sort of data shift point was at 9 months. So probing was successful in 94% of kids less than 9 months of age, and it decreased to 84% after 9 months. Katowitz looked at a large number of patients, 572, and success was 96% at less than 1 year of age, decreased to 69% during that second year of age, and down to 33% over 2 years. So that's a very significant jump. And Giva Manor et al. Had a smaller number of patients, but also very similar data trends. Next slide. So many options exist when initial probing fails, and we, as lacrimal specialists, often find ourselves in this situation. So first option is to repeat the probing. Perhaps the person who did it before wasn't as adept with the technique, and so you want to check things yourself, keeping in mind that repeat probing may be less successful as children become older. Katowitz found 54% success in second probings in children 18 to 24 months, and this decreased to 33% in kids older than 2 years. Additional options at the time of second probing, we always want to have additional tricks in our bag. So you could place silicone tubes, you can infracture the inferior turbinate, you could do a balloon catheter procedure, or a nasal endoscopic examination, which Dr. Bothra recommends on the first probing, which I think makes good sense if you have that equipment available easily. Next. So silicone intubation. This was described by Quickard and Dryden in 1970. The tube helps to dilate stenotic segments in the lacrimal system. We would do this under general anesthesia in children. The nose is packed with a vasoconstrictor. And then your lacrimal tube of choice, usually attached to metal probes, is placed through upper and lower systems. There is a trend now among some doctors of using monocanalicular stents with a punctal plug end. This makes for easier removal, but you only get half the thickness of the probes through the system, whereas if you do bicanalicular, the amount of tissue going through the system is larger. The probe tips are retrieved through the nose using a metal hook with a Crawford tube, or if you use a Rittling or other device, similar externalization techniques, the tubes are then fixated and tied at the appropriate tension. Next slide. So here's an example of the Crawford tube, which is my tube of choice. It has metal probe ends with a silicone part in between, and then I use a Crawford hook to retrieve this through the inferior meatus of the nose. Next. Complications of silicone intubation. You can always create a false passage during placement. The punctum can erode or slit, especially if the tube is tied a little too tight. You can get a reaction, inflammation, pyogenic granuloma around the punctum from irritation from the tube. The tube can be too loose and come outward on the skin side with a loop exposed. The tube can cause corneal irritation or abrasion, which is fairly uncommon, or you can get an infection. Next. Silicone intubation, timing of tube removal has been the subject of much debate. Many advocate leaving the tube in place for about 3 to 6 months, but good success is reported in as little as 6 weeks of placement. Success rates report ranges from 77 to 100%. I like this procedure because it preserves the normal anatomy. You're not creating a DCR passage. It's just trying to work with the native anatomy. Next. Infracture of the inferior turbinate is another technique that we often use. It was described by Jones and Wobig in 1977. The goal is to simply move the inferior turbinate away from the ostium of the nasolacrimal duct. It just physically widens the area, and if you're probing and making a new opening, hopefully it will help that opening to expand, as Dr. Bothra showed with her Freer elevator in her video. So to do the infracture, a Freer elevator is a great instrument choice. It's flat. You place it in the nose against the nasal wall, and you just push the inferior turbinate away from the wall medially, and you feel this sensation of a little crushing or movement as it gives way. And Havens and Wilkins reported 88% success rate in 24 patients doing a second probing with the infracture of the inferior turbinate. Next slide. Balloon catheter dilation was described by Becker in 1996, and although I believe it's not used as frequently in adults anymore, it is still quite popular in many centers for children. The reported success rate by Becker was 95% in 61 eyes, including 94% success in 34 systems that had previously failed a probing or intubation. Tau reported 77% success, including 75% in previously failed procedure cases. Seemed to be more successful in older patients in his study. And then Yüksel reported an overall success of 83% in 24 eyes, many of which had not had a previous procedure. But this was promising data because the mean patient age was 44 months, a group in which primary probing often has very poor results. Next. So here is a picture of the placement of the balloon catheter. You can see on the right, you want that balloon in the duct and then extending through the valve of Hasner area into the inferior turbinate of the nose. And then the little picture on the left shows the inflated balloon catheter. So you place it uninflated when you get it into the correct position, which you can use a nasal endoscope to verify this. Then you inflate several times, holding it for a number of seconds each time to allow dilation of the tissues. Next.
Sorry. So the balloon is inserted in the same way as we insert the probe. Now, once it's exactly similar to how you do the probe. And then you will see the balloon exiting into the inferior meatus through the NLD. So the first step is you do probing. Once you've done the probing, you've opened the inferior part of the NLD, then you insert the balloon and then you inflate it. How much? For 8 millimeters of water for about 90 seconds, right? And then you deflate it and then you re-inflate it for about 60 seconds. Again, 8 millimeter of water pressure. Okay, so you actually deflate and inflate the balloon twice. Why do you do it twice? Because you want that opening to stay enlarged. And why do you do it for 90 seconds? Then you give it a break and then you do it for 60 seconds because the vascularization around that area, you do not want it to get compromised. So you do it for 90 seconds, you give it a break for a few seconds, and then you again inflate it for 60 seconds. Now, again, if you keep on inflating it for a longer duration of time, there is a chance that there can that area can undergo vascular necrosis. You do not want that. So this exactly is the procedure for balloon catheter dilatation. And then after the dilatation, you do a irrigation and you see free fluid coming into the inferior meatus. Next.
We've already talked about nasal endoscopy and how important this is. It allows for the visualization of the inferior meatus and surrounding structures. There's some interesting data that's been published on false passages, and these can be quite common even in experienced hands. So Choi reported visualization of a false passage into the submucosal space in 5 out of 11 probings. And redirection of the probe resulted in successful outcome in 4 out of 5 of these children. McEwen did endoscopy in 52 lacrimal probings and found false passages in 15%. So even if you're experienced at this, don't underestimate the value of looking directly with an endoscope. Next. So dacryocystocele can be used when all the previous options have failed, or as Dr. Bothra mentioned, when you have an anomalous passage like into the inferior turbinate itself. So the DCR creates a bypass fistula between the lacrimal sac and the nose to provide an alternate pathway for tear outflow. An osteotomy is created adjacent to the middle meatus of the nose, and then the lacrimal sac is anastomosed with the nasal mucosa. This can be performed through an external incision near the medial canthus or through the nose with endoscopic visualization, and a silicone tube is routinely used in either approach. Next. External DCR was first described in adults by Dr. Toti in 1904, so it's a very old procedure. The overall success rate for DCR in children is about 85 to 95%, which is similar to the rate in adults. The main disadvantage of an external DCR is the cutaneous scar that's required, which can be tough for parents to see their children have a surgical scar. Next.
Right. So let's go through the steps of the external DCR. So here we are showing it on an adult, but the similar procedure can be done in a child as well. So first thing, always confirm your syringing findings, whether there is actually an obstruction. So here, because it's an adult, we just pressed on the lacrimal sac and saw regurgitation from the opposite punctum. Now you mark the incision, which is along the anterior lacrimal crest. If in a kid, of course, you will do it under general anesthesia. In an adult, you can do it under local anesthesia. When you're doing it under local, you need to give certain nerve blocks like the infraorbital nerve block, then the infratrochlear nerve block, which is midway between the supraorbital and the glabella. So you inject a little bit in that area for an infratrochlear nerve block. Then you give an ethmoidal nerve block so that the patient is comfortable during surgery. And then you locally infiltrate in the area of the incision. Now, this local infiltration, you have to do it irrespective of your anesthesia, even if you're doing it under general or local. Then you take some lignocaine jelly and you anesthetize the nasal cavity. Now here you can also use some xylometazoline or oxymetazoline nasal drops to get some decongestion into the nose. Now what is important is the direction. Always stay parallel to the face. Whenever you are decongesting or inserting the nasal pack, just stay parallel to the face. Do not go perpendicular, because if you go perpendicular, you're actually going along the floor, which is not where you need the nasal packing. Can you completely avoid the nasal pack? Yes, you can. Just use a little bit of decongestant nasal spray into the nose. Now you use a 15 number blade and you take the incision along the anterior lacrimal crest. Now, of course, this surgery is going to be a little bloody, right? You cannot do the surgery without seeing any amount of blood. Then you use your scissors and just separate the orbicularis fibers. Now, once the orbicularis fibers are separated, use a cat's paw retractor and do gentle separation of these orbicularis fibers until you see a bare bone. Right? Now, once you see a bare bone, you use a cautery or you can use just a periosteal elevator to actually take a periosteal incision. Once you've taken the periosteal incision, this periosteum is then retracted superiorly as well as inferiorly towards the anterior lacrimal crest. So this is the superior retraction. Then you hold the edge of the periosteum and retract it inferiorly. Now the edge of the bone that you're seeing is the anterior lacrimal crest, and that is your lacrimal sac fossa with your sac. Now I tend to use a gauze to separate the sac from the sac fossa. Now this serves two purposes. One is separation. Second is it also helps us achieve a little bit of hemostasis. Now you can see clearly into the lacrimal sac fossa. You'll see two bones there, the frontal process of maxilla and the thin part which is in the posterior side, which is your lacrimal bone. You perforate the lacrimal bone and then you start your osteotomy using your bone rounders. Now, using your bone rounders, you will make your osteotomy big enough such that your entire sac is then exposed to the nasal cavity. So what is your anterior endpoint? Till you cannot insinuate your probe into the in between the nasal mucosa and the bone. Inferiorly, until you see the nasolacrimal duct. So if you actually follow your sac tissue, which is near your cat's paw retractor, you can now see your nasolacrimal duct. So until you see the nasolacrimal duct, you will do the osteotomy. Once your nasolacrimal duct is free of any bone, then you proceed anteriorly. You do anteriorly till you cannot insinuate your roundure between the mucosa and the bone anymore. So that should be your endpoint. And what is your endpoint superiorly? Until your entire sac fundus is free of any bone that is in front of it. So one large piece of bone is still pending, which is right exactly in front of your sac. The grayish mucosa that you see below is your ethmoidal mucosa. That automatically indicates that you're very close to completing your superior osteotomy. So very closely observe the different colors that you're seeing. The ethmoidal mucosa is grayish in color. The sac is light pink in color, whereas your nasal mucosa is reddish in color. So you should be able to distinguish these mucosas from each other so that your surgery is smoother and you understand the landmarks. Now, once you've done that, you again dilate the puncta and you put in a probe. Now, this probe will help you visualize whether or not your sac is completely exposed and whether there is any amount of bone that is lying in front of your sac. So now you insert the probe. We've already seen how to do that in our probing video. But here you will just direct it absolutely parallel to the horizontal palpebral fissure. And then you see it pointing into the cavity and you see that there is absolutely no bone in front of it. That means your osteotomy is complete and large enough such that there is going to be no obstruction to the flow of tears. Now you take a 11 number blade and you take a small incision onto the sac. You'll see an egress of the discharge, and I tend to use conjunctival scissors post this to extend the incision both superiorly as well as inferiorly. Now, as we all read in our books, we have to take an H-shaped incision. So this is the horizontal incision, and now you take two vertical incisions on either side to create the H. So this is your anterior lacrimal flap. So after you take the incisions vertically, that your anterior flap is completely free, and then you see the probe coming in freely into the cavity. Now, similar vertical incisions are taken on the posterior lacrimal flap such that it just falls behind. So your aim is to open the sac like a book so that it is exposed to the nasal cavity entirely. So now you will go ahead and make vertical cuts on the posterior flap. So you can see now the flap is nicely falling down and the sac is completely, or the common canaliculus is completely exposed to the nasal cavity. Now in a similar way, so that is the anterior flap and then the posterior flap, right? Now in a similar way, we will take nasal mucosal incision using a 11 number blade. Be careful not to take the incision onto the septum. And then once you've made that initial cut, you use your conjunctival scissors to make the horizontal cut superiorly, inferiorly. And then just like how you did for the lacrimal flaps, you would give vertical incisions such that you create an H-shaped flap. So again, that is your anterior nasal flap, right? And similarly, you will create a posterior nasal flap, giving vertical cuts. Now, the structure that you see inside is your middle turbinate, which is where in the nose, if you're looking beyond the nasal flap, the pink structure that you're seeing is your middle turbinate. Now, once that is done, mitomycin C is applied. It is we use 0.02% mitomycin C and leave it inside for about 3 minutes. Now, after this is done, the first step is suture both the posterior flaps. Now, why do you want to suture it first before putting the intubation? Because you don't want your intubation tube to get entangled in the suture. So the first thing is take a single suture at the posterior flap. So that was the suture through the nasal flap. and this is through the lacrimal flap, such that the edge to edge of both the flaps oppose each other. Once the posterior flap is in place, we do a bicanalicular intubation. Now, whether you should do an intubation in all cases, well, in a case like this, where you see flaps are nicely made with no injury to the common canaliculus, if you do not have access to intubation, it is perfectly okay to just leave it like that. Now, I use a suction catheter and I feed this probe into the suction catheter and I just pull it out of the nose. The other way to pull it out through the nose is using an artery forceps, going in through the nose and holding the stylet of the intubation tube and then just pulling it out. So as you can see, when you use a suction catheter, there is minimal trauma to the nasal mucosa because it's like a pipe and you feed it into the pipe and you just take it out using your bimanual movement. So you push it from top and you pull it from down and your probe is secured. Now, once your intubation is in position, you will go ahead and suture the anterior flaps. Make sure that you do not include your intubation or your stent into the suture because that is going to create a problem when you're actually removing the intubation tube. Now, intubation is usually kept in for about 4 weeks in our setting, but you can keep it for as long as 6 weeks. We tend to avoid keeping the intubation in place for more than 6 weeks because it leads to a biofilm formation and that can cause inflammation and failure of your surgery. So try avoid keeping it for more than 6 weeks, right? Now, once you're done with the flap, I tend to fix it to the overlying orbicularis so that it is tented up and it does not fall back down. And then you directly close the skin. Right. So I think we can move on to the next slide, please.
So another look at success rates for pediatric DCRs. This slide combines reports by a number of authors for external and endoscopic techniques. For external, these 4 reports have 586 patients with a success rate of 88%, and we have 66 cases combined from these studies with an 85% success rate. So these are good numbers. Next. The earliest descriptions of endoscopic lacrimal surgery through the nose were in 1893, 1910, and 21. Of course, there's been a lot of improvement in endoscopic equipment that have led to a resurgence of interest in endoscopic DCR starting about 25 years ago. Next. And so here is an endoscopic DCR.
Yeah, so as Dr. Freitag mentioned earlier, there's nothing worse than seeing your child with a scar. So if you want to avoid that scar, you would actually go ahead and do an endoscopic procedure, which is far more simpler procedure as compared to your external. So let us just understand the landmarks. So you see that thing hanging there, that is your middle turbinate. Now, where it attaches to the lateral wall is the axilla. Your sac lies anterior to it. Now see, I'm injecting a little bit of lignocaine adrenaline in the area where I want to incise. Now this is precisely the area where your sac lies. So it is anterior to your middle turbinate. Right? So you inject a little bit of lignocaine adrenaline combination into the mucosa and you pack the mucosa with sponges which are soaked in lignocaine and adrenaline. Now this is very important so that you can have a bloodless surgery. Now I've given a very small injection into the septum as well, just so that it decongests and is out of my way during the surgery. Right? So these are sponges which are soaked in the same lignocaine adrenaline solution and kept inside the nose. Now let us start the surgery. So first is remove all these packs that you've inserted. Now you see it is a nicely decongested cavity. You can see the overhanging middle turbinate. Now use a 15 number blade, go up till the axilla, a little higher than the axilla of the middle turbinate. Take a horizontal incision for about 10 to 12 millimeters. Then you take a vertical incision for about 10 to 12 millimeters. And usually it is up to 2/3 the length of the middle turbinate, and then you join it behind. Now, once you've done that, use your periosteal elevator and just retract or reflect this nasal mucosa posteriorly. Now, once you've done that, you will see that there is an edge of the bone that you see over there. That is what is called as your maxillary line. Now, anterior to that maxillary line is frontal process of maxilla. Posterior to that is your lacrimal bone. So that is exactly the place where your lacrimal sac fossa is. Now, once that area is absolutely clear, you would go in with your rounger and at the inferior most point, just break away the bone. And now let us press the sac from outside. You will actually see a nice movement of the sac happening on the inside. Just have a look. Can you see the movement happening inside? So that is your lacrimal sac. Now you go ahead with your rounger and just enlarge this osteotomy. So this is a much shorter procedure as compared to your external DCR and is much more physiologic. Can you see that movement now? On pressing on the outside, you can actually see the movement of the lacrimal sac on the inside. Now you go ahead and complete your osteotomy. So what is the end point? You put in the probe as I showed you earlier during the external DCR, and you see directed absolutely parallel along the horizontal palpebral fissure. And in front of that, there should be no bone. That is your endpoint of the surgery. So again, remember the colors of the mucosa. You have to identify that once again. So the ethmoid mucosa is slightly grayish in color, sac is slightly pinkish in color, and here you won't see the nasal mucosa, which is slightly more reddish in color. So you can now see that our osteotomy is nearly complete. This thin bone that is being reflected from the surface of the sac is your lacrimal bone. This bone can just be removed with the help of an alligator forceps. So this is the alligator forceps. Be careful not to pull any mucosa, else that will cause bleeding. If it is attached to the mucosa, you can use your periosteal elevator to separate the bone from the mucosa and then just remove that bone. It comes off very, very easily. There. So that is your thin lacrimal bone, which is what you perforate when you do an external surgery. Now you can see there is a huge chunk of ethmoid bone, which is sitting right in front of your lacrimal sac. So this bone is again separated from the mucosa on all the sides. And in using an alligator forceps, this bone is also completely removed. Now you put in a probe and then you look at where the probe is exiting. Is there any bone in front of it? Look at the topmost part of your lacrimal sac. You can see the probe coming in. You can see that there is no bone in front of it. Now, once you've achieved that bit, if you see a bone in front of it, you can use either your rounger or you can use a powered drill like what I'm using here to smoothen the bone superiorly. Why is it important? One, superior bone is much more thicker than any other place. See, look at the thickness of the bone. Sometimes the rounger cannot really account for thickness of the bone that much. So in those cases, you can actually use a powered instrument like a drill to just smoothen out the bone and increase the osteotomy. Right? So now there is no bone. Now we use a crescent blade and we give an incision onto the sac. So an H-shaped incision as we spoke about. So first is the vertical incision. Once you've given the vertical incision, with the same thing, you give back cuts. There are two horizontal back cuts, superiorly and inferiorly. So your posterior flap just falls back. You see the egress of the mucopurulent discharge. And then similarly in the anterior, and you see the probe exiting out. You see the interior of the sac. A similar horizontal incision is actually taken on the anterior flap as well. And then using a ball probe, you can actually turn the flaps outside such that it opens up like a book. Mitomycin C is applied again for 3 minutes. Once that is done, a bicanalicular stent intubation is done. Now, endoscopic surgery, suction is not needed. You can use the alligator to just pull out the probes. Once that is done, the flaps are put in position. So there we suture the flaps in external DCR. Here we cannot suture the flap. It is very difficult to suture inside the nasal cavity. So what we are going to do is push the flap behind, push our nasal flap, which we had reflected behind again. Make sure that there is an edge-to-edge apposition. Once we achieve that apposition, what we use in our practice is fibrin glue. So you can see the posterior flaps are opposed to each other, and here I am putting in some glue so that it stays opposed. So that is the end of the surgery. Right. Next, please. Yeah.
So now we're going to shift gears a bit and look at upper lacrimal system surgery. So congenital anomalies of the upper system may be managed by reconstruction or bypass. A focal segment of a canalicular stenosis, for example, can be simply excised and then the ends anastomosed over a stent. And fistulas can be excised. So let's look at this a little more. Next. Another procedure that we use for upper system obstructions is a conjunctival dacryocystocele or CDCR. This was described by Dr. Jones in 1962. This is a creation of a direct bypass between the medial canthus or ocular surface and the nose. This is used if the punctum and canalicular system are not patent or able to be repaired. And a glass tube called a Jones tube is placed between the medial canthus ocular surface and the nose. Next. CDCRs in children, we don't do very often. Wellham and Hughes described 5 cases in 5 children with punctal and canalicular agenesis. I think for these to have long-term success, they must have made these children sit in a chair their whole lives because they tend to fall in or fall out, even in highly reliable adults. And if you sneeze, they can blow out. So it requires a very high amount of compliance for patients to keep these in place. Hakin had 10 of 11 successful DCRs in children. But again, the long-term follow-up on these, I would love to see. Next. CDCR complications. So the most frequent complication is extrusion of the glass tube externally or migration into the nose. These, as I mentioned, are really hard to maintain in children who are active. Adults can tolerate in-office manipulations of the tube if it's a little deep or needs to be cleaned out. Children may require anesthesia. The tubes can become blocked. Debris can collect internally inside the glass. You can get a granuloma formation or possibly an infection. Next. So we're back to a little more discussion on congenital dacryoceles or dacryocystocele, same thing. You want to ask parents if their children are having any difficulty breathing or feeding, because you can get intranasal cysts that can be related to these obstructions. And the bottom slides are showing pictures, endoscopic view of some cysts. So the treatment is irrigation and probing with endoscopic guidance, opening of the cysts, and lacrimal sac compressions in the interim. Next. These, as I mentioned, have different names: amniotocele, dacryocele, mucocele. They usually present around the time of birth. They're most often unilateral, and they can look pink or blue under the surface of the skin. And initially, they're usually sterile and have a dilated lacrimal sac from fluid. Next. As I mentioned earlier, you often have a proximal and distal blockage, which cause these at the valve of Hasner and Rosenmuller. Next slide. And complications can include infection. Patients can get preseptal cellulitis. Occasionally, they could form a fistula if this opens up to the skin. They can cause pressure, expanding the system out into the nose, causing intranasal cysts. If they're quite large and untreated, they can induce astigmatism and cause amblyopia. Infection or dacryocystitis occurs in a widely reported range of cases and warrants surgical intervention. Next. Nasolacrimal duct obstruction associated with these cysts was described by Rafflo in 1982, which is quite interesting because obviously these have been occurring since the beginning of time, but no one really described it until 1982. We have to remember that small children are preferential nose breathers. So if they have large cysts obstructing their nasal passageways, this becomes quite concerning. It can lead to respiratory distress and need urgent surgical intervention. Next. Here are more examples. There's an axial CT slice on the left with a little arrowhead showing an intranasal nasolacrimal duct cyst, and we get an endoscopic view of this patient on the right. Next. And here is a link to Dr. Bothra's videos and information. As you can see, it's a really remarkable collection, and so I hope you'll take note of this. Next.
Right. So now we're coming to the end of our presentation. So when you see a kid presenting with epiphora, is it always congenital nasolacrimal duct obstruction? No, we need to rethink. So what are the other mimickers? So let us just go through a few of the cases. Next. So punctal agenesis. So if you always need to ask the parents that is there watering along with a lot of mucopurulent discharge, or there is just minimal discharge. Now, when you have minimal discharge, but a lot of watering, that is when you should suspect there is something wrong or something going on with the puncta as such. So in this situation, you should always look at the puncta. So how does punctal agenesis look? So look at this picture on the lower eyelid. You see that there is no punctal papillae. There is no punctal opening. If you actually look on the pars lacrimalis portion of your eyelid, that is the one that is medial to the puncta, you will see that there is no that there are hair in that area as well. That hair indicates that the development has not happened properly. The other very subtle thing, when you look at these patients under a microscope or under a slit lamp, you would see that there is a hollowness in the area where the canaliculi should be. So these are just subtle signs that you should notice. And that is when you realize that this is actually a punctal agenesis and not a congenital nasolacrimal duct obstruction. Now, these cases can be associated with ocular and systemic diseases in about 23% of the cases. Thus, it is very, very important to recognize this entity. Next. So, okay, before we move on to incomplete punctal canalization, if you have punctal agenesis, your treatment option is conjunctival dacryocystostomy, as Dr. Freitag described, which is creating a passage directly from the medial canthus to the nose. Right? A DCR or any other procedure is not going to work in those cases. Now, coming to the second mimicker, it is called as incomplete punctal canalization or an IPC. Now, here, look at the image here. Now, in the center of the image, can you see a depressed area with vessels on it? Now, that is the area of your puncta. And you see that there is a nice membrane which is overlying that punctal opening. Now, so here what happens during development, there is failure of the dehiscence of epithelium over a normally formed canaliculi, or just as there is failure of canalization at the nasolacrimal duct in CNLDO, there is failure of canalization of the punctal opening in these cases. What do you do? Next, please. So it's very, very simple. So similarly, we took an OCT through that puncta. And what do you see? You see a nice vertical canaliculus where the arrow is pointing. But look at the opening. There is no opening onto the surface. There is a thick membrane overlying this opening of the vertical canaliculus. Next. So how do you treat this? Next. Yeah, so you use a dilator. Now there are two dilators that I've put over here. The one on the left is your short taper punctal dilator, and the one on your right is a rapid taper punctal dilator. You see it is tapering very rapidly and is pointed. This is the dilator that you want to use. You just go in and you puncture that membrane. Once you puncture the membrane, you do an irrigation, and in 98% or 99% of the cases, there is no associated other anomaly, and the syringing is freely patent after you perforate this membrane. Next. So there are, as I said, there are no associated systemic anomalies. Sometimes, that is very rarely, it may be associated with a canalicular stenosis or an underlying congenital nasolacrimal duct obstruction, in which case you already know what to do. So whether we need an intubation after we break the membrane? No, we don't need an intubation. These membranes don't form again. It is very similar to the one that we open in the nasolacrimal duct. We do not really need to put in a stent. Similarly, over here also, we do not really need to put in a stent. Next. Coming to the next mimicker is a canalicular wall dysgenesis. Now, these kids will actually come in with complaints of epiphora, which is just water. There is no discharge, and the epiphora is minimal. There is not too much of epiphora. If it is associated with an underlying nasolacrimal duct obstruction, there will be excessive epiphora and discharge. But why is it important to recognize this condition? Can we move on to the next slide? Yeah, so it is important to recognize this condition because here, as you see, the canaliculus is not completely covered with all the layers that it is supposed to be covered with. So the muscle layer is missing in all of these cases. So when the muscle layer is missing, the lacrimal pump function is affected. It is not absent, but it is affected. So even if you go ahead and take care of the underlying nasolacrimal duct obstruction, there may still be a little bit of persisting epiphora, which is very important for us to explain this to the parents so that they do not really get bothered that, oh, you did the procedure, but it is still watering. So it may water a little bit, but it is going to be much better than what it was because of the underlying nasolacrimal duct obstruction. Next. So how do you recognize this? As we already saw, you put in a probe and then you see the probe is completely visible when you put in through the canaliculus. There is either a thin membrane which is covering the probe, or sometimes if it is an aplasia, you can actually see the entire wall of the canaliculus is missing. It can be associated with certain local and systemic pathologies. And implications we already discussed: weakness of Horner muscle function, therefore weak lacrimal pump function. And also, whenever you're doing probing, when you turn the probe vertically, be very, very careful in these cases, because sometimes you can perforate and cause an entire canaliculus to tear. So that is why you have to be very, very careful when you're doing probing in these cases. Okay, next. The last part where you may have some amount of epiphora because of weakness of a lacrimal pump function is something called as a supernumerary puncta, where you see more than one puncta. If you look at the lower eyelid, you see two openings, right? One in the actual place and one on the canaliculus. So this can also cause minimal epiphora, but there is no discharge, and generally there is no associated other anomalies. Next.
So moving down the system a little, next we'll talk about congenital unlocked ducts and lacrimal fistulas. So these are often well defined. They're usually inframedial to the normal punctum in location, and they usually have smooth, regular edges. Next. Here's a nice picture of a congenital lacrimal fistula. You can see it inferior and medial to the medial commissure with a little drop of fluorescein. So this suggests that there is some connection with the lacrimal system. These occur in about 1 in 2,000 live births by report. In my own personal experience, I think it's probably more rare than that. They can be bilateral, they can have multiple openings or end in blind pouches. I had a patient recently with 2 of these on each side, and most of them were blind pouches. If you look histologically at these structures, if you remove them, They are similar to a normal canaliculus with non-keratinized stratified squamous epithelium. Next. If they're connected to the system, they can result in epiphora. The fistula can become infected, and it can cause focal dermatitis from chronic lacrimation. I've had a patient who collected a bit of keratin in these and caused some itching and irritation. Next. The condition is often sporadic, but can be autosomal dominant. And these fistula have been reported in conjunction with other anomalies such as nasolacrimal obstruction, mucocele, absent canaliculus, contralateral absent punctum, total agenesis of lacrimal system. So clearly, if there's a fistula, something's not right with the lacrimal system, and there may be other lacrimal anomalies. Next. So the management depends on the symptomatology. It's perfectly fine to leave these alone if they're not causing a problem. Reports have shown the following strategies for dealing with them: cautery, simple closure, excision of a fistulous tract, which is my preferred technique, and I'll show you on the next slide. If there's associated NLDO, you would consider a DCR, silicone intubation, or common canalicular dissection. Next. So this is a great article by Tim Sullivan, and it shows a young person with a congenital lacrimal fistula with the arrow pointing it out. This is the procedure I use. I place a Bowman probe as far into the fistula as I can. Some are a blind pouch, and some do connect up with the lacrimal system. I then take an 11 blade followed by a small scissors, and I just cut a circle of skin and fistula around that probe while the probe is in place. And then I put simple cutaneous sutures in. Next. So mass lesions can simulate NLDO. If someone has a lump in their medial canthus, we want to consider a lacrimal obstruction, but we don't want to miss an encephalocele. Now, encephaloceles usually have quite anomalous facial changes, and so you would see telecanthus or a widened nasal bridge area and some other changes. So, but we don't want to miss an encephalocele. Hemangiomas can occur in the area of the lacrimal sac. You could get a dermoid cyst, a nasal glioma, lymphangioma, a lacrimal sac primary tumor, rhabdomyosarcoma, ethmoiditis, pneumatocoele, and most have atypical findings from a lacrimal obstruction. And radiographic imaging can be helpful if you're worried about other things and want to prepare for surgery. So next slide. This is the home stretch, just a few comments about radiographic imaging. Most cases of congenital lacrimal obstruction are managed without imaging studies. You want to consider imaging if there's an atypical presentation or anatomy, or if previous treatments have failed and you're stumped and you want to get more information. Next. So dacryocystography, DCG, is where you inject contrast into the lacrimal system with a lacrimal cannula. Plain film radiographs are taken with the patient supine and in a Waters position. Then you can show the areas of lacrimal stenosis, diverticuli, and correlate this with the bony landmarks, which are visible as well. You don't get soft tissue information from this type of study. You can also do it with fluoroscopy equipment. Next. And so here's an example of a dacryocystogram. So on the patient's right side, you can see the contrast dye in the tear film along the eyelid, and you can see that the cannula is into the lacrimal system, and you can see dye going down through the system and into the nose. Then on the patient's left side, you can see that the lacrimal sac contains 3 little globs of contrast material, but then there's an obstruction at the sac duct junction, which is a common place for an obstruction in adults. Next. You can also inject dye and then do a CAT scan. Here you see a CT DCG where dye is injected into the lacrimal system and axial images are obtained, then you can reconstruct them in 3 dimensions and even rotate them to look for areas of obstruction. And MRI is a similar concept. You would use MRI contrast material injected into the system, and then do your studies and reconstruction. Next slide. Dacryocystitis is often considered in children because it's non-invasive. It doesn't require cannulation of the system. And so technetium-99 solution is placed on the surface of a globe just as an eye drop is placed. And then a gamma tracer takes pictures as the material works its way through the system. So you need the child to cooperate for about 20 minutes, which can be challenging. But you want the child awake because a sedated child won't be blinking and operating their lacrimal pump apparatus. So this study not only looks at the anatomy, but it also considers lacrimal pump function. And you don't get any visualization of the surrounding landmarks. It's just looking at the dye. Next. So a few summary slides. Congenital nasolacrimal duct obstruction is common, occurring in about 6% of newborns. About 90% of cases will resolve by 1 year of age with conservative management. The most common site of the obstruction is the valve of Hasner at the nasolacrimal duct nose junction. Persistence beyond 1 year of age warrants intervention because the results of intervention decrease significantly as months and years go on. Next. Probing is a typical first intervention for congenital nasolacrimal obstruction. The success rate of probing is around 90% when performed at 1 year of age, and it gets lower as the child ages. A second probing is usually performed after a first probing, and you want to consider additional procedures if you're doing a second probing, such as intubation, infracture of the inferior turbinate, or balloon catheter dilation. Continued obstruction warrants consideration of a DCR, either external or endoscopic. Next. Obstructions at higher points in the lacrimal system are less common. Radiologic imaging such as DCG can help localize the site of atypical obstructions and guide management. Obstructions of the upper lacrimal system are treated by primary anastomosis of functional tissues or by CDCR bypass. So that is the end of our presentation.
So the one question was, would there be any side effect of fluorescein during the FDDT? So there is no. The answer is none, because fluorescein as such does not have any side effects, right? Dr. Freitag, the next question is, in dacryocystitis in newborn, do you use antibiotics several days before probing, or some antibiotics and massage can solve the problem, or do you use antibiotics in dacryocystocele?
Well, we have to question, are we talking about oral antibiotics or topical antibiotics? So for children who are just a little crusty on the ocular surface without a dacryocystitis, certainly topical antibiotic can be helpful in the form of antibiotic ointment. If someone really has a dacryocystitis, then systemic antibiotics are indicated. And just like in adults, if someone has a very significant dacryocystitis, you want to time your DCR surgery for them to improve a little bit, because the tissues can be distorted and quite friable if there's a significant infection. But if you're somewhere in between with a young child with a congenital obstruction, I think going ahead with probing is reasonable. Nandini, any other comments on that?
No, I think I agree with what you said, but also one more question, like I've already answered that one, but they are asking, if you use the antibiotics, which antibiotic would you prefer? Like in our practice, we use tobramycin eye drops if I have to give a topical, but if I have to give a systemic, we prefer amoxicillin clavulanic acid combination. So is that anything that you prefer?
I think it depends on knowing the region in which you're practicing and the risks of MRSA and other infections. We've had some children recently living in homeless shelters and other high-risk places who have had quite interesting flora in their periorbital infections. So I think knowing your region and taking a careful history of the patient to know whether they're at risk for atypical organisms, but in general, clavulanic acid amoxicillin is a good choice for a routine situation.
Yeah. So one very interesting question that was there was, can you use a nunchaku stent instead of a Crawford stent in congenital NLDO? So for this, actually, I would say nunchaku stents are they are really very good, especially if you don't have an endoscope with you. Because with nunchaku stent, the advantage is it automatically goes inside your NLD into your inferior meatus, and at one point you will get a click. And when you get that click or you feel a click on your hand, that is when you know that the stent has engaged inside, and you just withdraw the stylet, which is inside the probe. So what it is, a self-retaining stent. So here if you don't have an endoscope, you don't have to pull anything from the nose. It automatically goes and sits into your NLD. So if you don't have an endoscope and you're not very well versed with using it, then you can actually use a nunchaku instead of a Crawford stent. Dr. Freitag, any experience with nunchaku stents?
I don't use them often, but monocanaliccular stenting really is becoming quite popular. And at our children's hospital here in Boston, I know it's done frequently. They seem happy with the results, and it's a lot easier to get the tubes back out again.
Yeah.
Here's a good question or comment. Do you give topical steroid after probing to prevent scarring? It's common here in Nepal. Nandini, your thoughts on that?
So I give for a week steroids after perforating, like 4 times a day for a week, and I stop. I don't taper it. But even if you don't give it, it is perfectly fine. In our experience, I've tried both and both works.
What is the minimum age for performing DCR in children? I mean, you do it when if someone is badly infected and there's no other way around it, you would have to think outside the box. But I would say probably about 1 year of age, in my opinion. Nandini, what would you say for that?
So I've operated a kid as young as a 21-year-old child because the child had bony obstruction. The child needed an urgent corneal transplant, and and there was an excessive discharge from the eye. So the corneal surgeons were not ready to go ahead with the transplant, and rightly so, without us clearing the without us clearing the lacrimal passage. So the child was 21 days old and we had to go ahead and do a DCR. But unless there are some pressing conditions like, say, repeat episodes of acute dacryocystitis or lacrimal abscess or an urgent need for an intraocular procedure, it is better to wait up till 5 years of age so that the bone growth is complete, and we take the child up for surgery then.
Another question, how to avoid the angular vein trauma during external DCR surgery? If it's injured, how do you manage it? So Dr. Bothra's video was just exquisitely beautiful anatomically, but actually angular artery and angular vein are hit on DCRs almost every time, and you just cauterize it and it's of no consequence. So that's an expected part of DCR surgery.
Yeah, just one more point to add. I think I answered one question above where they asked me what is the difference between the anterior lacrimal crest incision versus a medial canthal incision. So that is where your angular vein can be damaged most commonly when you take a medial canthal incision. So a medial canthal incision means about 7 to 9 millimeters medial to the medial canthus. And that is exactly where your angular vein crosses. So if you want to avoid it, first thing is go anterior lacrimal crest. The other second part is, even if it is injured, as Dr. Freitag was saying, just hold it and cauterize it. It is of no real significance.
All right, well, I think we've kind of reached a hard stop on our time allotment today. So I want to thank Orbis and CyberSight for allowing us to present this webinar. And thank you to all of the people who have attended for your attention and your excellent questions. So thank you so much and have a great day.
Thank you, everyone. And if there are any questions, you can always mail either of us and we'll be happy to take it.